Good afternoon and welcome. It's a good week to be in Seattle. A little bit cold, but still a good week in Seattle. This is one of my favorite events. I really appreciate the chance on the annual basis to say thank you. We have a very large UW-Medicine community, about 25,000 employees, nearly 5,000 students and trainees. And all of you, the nearly 30,000 members of the UW-Medicine community, are doing truly excellent work in your research, in your education, and in your clinical care activities. And that means that you are advancing our mission of improving health. Today's talk is titled UW-Medicine's Role in Improving Health. That's really what you all are doing on a daily basis. So this is a day that I'm grateful to have to say thank you to all of you, to all members of the UW-Medicine community doing this outstanding work. And today, in addition to those of you who came in from the cold to Hogness Auditorium, we have colleagues at Valley Medical Center, Harborview Medical Center, South Lake Union, and Northwest Hospital and Medical Center who are joining us by video. So welcome to all of our colleagues around King County. This past week has been a good week for Seattle. I promised to not talk about the Seahawks today. I did that in a talk earlier this week. Well, I guess I'll say one thing about the Seahawks. I think Russell Wilson is a good role model. My 4.5-year-old grandson certainly thinks he's a good role model, wants to be just like Russell Wilson. When Russell Wilson is talking in an interview or in any setting, you'll notice he always says, what? Go Seahawks. Go Seahawks, he includes in every time he talks. What I want to do today is, in addition to thank you, is I'm here to say, go UW-Medicine. Now, the last few years, I have used the word change many times. I have not used the word transformation intentionally. I might have used it, but I don't think I used it in my talks formally. Transformation is a word that in some ways is overused, probably why I've avoided it a bit in the past. But it's a word that I think we should consider using to describe what is going on with UW-Medicine. Transformation, like many words, has different definitions. A reason why I'm suggesting we should use it to describe what we're doing is one of the definitions is that transformation is the act of changing something completely and usually in a good way. Well, we're not changing completely. I want to emphasize that in that way, transformation does not apply to us. Our mission sits at our core. Our values are long-standing. We're not changing completely, but we are doing our very best to change in a good way. Now, there's scientific definitions of transformation, genetic modification of bacteria. There are organizational definitions of transformation, a process of profound change that orients an organization in a new direction and takes it to a different level of effectiveness. That definition of transformation does apply to what we're doing now in UW-Medicine. There's also a clinical definition of transformation, transforming healthcare to a model of value-based, high-quality, and service-oriented care of the patient. And of course, the transformation that is going on at UW-Medicine now is occurring in the setting of the nationwide and really global shifts in healthcare. I talk on a regular basis with other individuals in the US leading large healthcare organizations. I also have the opportunity to talk, including yesterday, with individuals around the world leading large healthcare organizations. We are all around the globe sharing similar challenges. Around the globe, although this term began in the US with Don Berwick credited with the term triple aim, but around the globe, the triple aim is being used as a guide for the type of change that healthcare systems need to implement. The triple aim involves better health care for the individual patient, meaning improved quality, improved access, improved service of healthcare for the individual patient. It involves striving to improve the health of the population we're serving, and very importantly, and it involves a reduction of per capita cost in those programs. Around the globe, whether you're in a UK type system, in Germany, in France, in the US, around the globe, this triple aim is driving what we need to do in healthcare. Now, in our setting, where we integrate our education and research activities with healthcare delivery, it's very important for us to be coordinating and integrating the plans we have for our education program changes and for our research program changes with our overall mission of improving the health of the public, which can be guided by this triple aim of better health care for the individual, better health for the population we serve, and a focus on a reduction of the per capita cost. I've been in healthcare for a long time now. I won't say how many years, but I can tell you honestly, I have never been more enthusiastic about our opportunity to transform what we do, meaning change what we do in a way that is good, in a way that is consistent with our mission of improving health for all people. Where we are as an organization now, I believe, is in the midst of truly significant transformation. We are adapting and we are changing dramatically, and much of that change, I think, is really for the better. This success that we've had thus far, I want to emphasize, is due to the work of 25,000 employees and our students and trainees. Another 5,000 people are contributing to this work. So it's really the outstanding UW Medicine community that is at the core of our success. Another reason why we're successful is we are an organization that's taken what we've learned in the clinical setting of continuous quality improvement and applied that continuous improvement approach to virtually every major activity that we're undertaking in UW Medicine. So we are learning, we are, in the words of the Institute of Medicine, a learning healthcare system. We are continually improving. Now, before I go on to describe some details about the transformation in UW Medicine, I want to be sure everyone received a packet of information outside, and I hope those of you at Valley and Northwest and South Lake Union and Harborview have this packet. This talk is a real challenge for me. I cannot possibly begin to cover all of the amazing work that people in UW Medicine have done in the past year. And so with these handouts, we attempt to describe a sample of the work. The handouts include a fact sheet describing UW Medicine. I will not be covering that fact sheet, but please take some time to familiarize yourself with the mission of improving the health of the public and some of the basic facts of UW Medicine. The packet includes an executive summary of our annual financial report to the UW Board of Regents about the UW Medicine finances. Your packet has an executive summary of that report. The full report is online if you'd like to read the full report. We continue to be financially stable. And one point I will mention is that you, the faculty and staff and students in UW Medicine, are responsible for that stability, including in this very difficult year with NIH, this past year with NIH, including the faculty raising over $1 billion in research funding again. That's really an amazing accomplishment. The packet also includes a year in review summary. This is just a sample of work and awards related to teaching, research, and clinical activities. A number of individuals are mentioned, individuals like Andy Luck and Heidi Coombs, who are outstanding teachers and have retired the teaching award. Individuals like King Holmes and Mary Claire King, who have received the most prestigious research prizes anyone can receive. And the administrative appointments that are always important for us, individuals like Ann Ecker, who was appointed as Associate Dean for Student Affairs, Cindy Hecker, who was appointed as Executive Director at Northwest Hospital, And among many other appointments, Eric Holland, who joined us from Sloan Kettering as the director of the Buster and Nancy Alvord Brain Tumor Research Program. So please take a chance to see what some of your colleagues have done in this past year. The last document you have is a UW Medicine in the News review. And again, this is just a sample. It goes from Dr. Oz to NBC Evening News to the Washington Post to some very small newspapers in the WWAMI region, and truly news from around the world in areas such as accomplishments in the Institute for Health Metrics, what Chris Murray and his colleagues are doing with the global burden of disease, and a number of other areas where you'll see that it's the New York Times, the Washington Post, Seattle Times, and papers around the world that are covering what all of our community members have been doing. So I can't cover all that, but that's, please look at those documents. So now I'd like to move to a discussion of what I'm calling continuous improvement leading to transformational change. We're in the midst of this transformational change, whether it's in our research programs, our teaching programs, or our clinical programs. And I'd like to show some samples of what I consider to be leading transformational change. I don't think anyone would disagree that this is the most exciting time in history for biomedical research. It's moving faster than ever. We can solve more problems than we could ever solve before. And key to these advances in some ways is the leadership that we have in UW Medicine in genomics and precision medicine, and now in a relatively new field of protein design. I'll let some faculty involved with the precision medicine describe this.
We have a long history of precision medicine, or the kinds of things that we're now calling precision medicine, which is really to try and identify the individual variations in people that make a difference in terms of our ability to make diagnoses, to treat people accurately. Our UW Medicine Precision Diagnostic Center is a new thing that was developed after it was recognized that we had all of the facilities and the people, the technology here, and it needed a home so that we could use the experience and the technologies at UW Medical Centers and the associated parts of it to make a difference for people's lives and for patients.
Even without the genetics, people have a knowledge of their family history, of their risk for cardiovascular disease, but perhaps in some cases individuals actually knowing they have a predisposition for it by looking at their genome might have a slightly different effect on whether or not they would do something about it, or whether they could do something about it. And knowing your genetic makeup can give you some idea of what might work for you and what might not.
It has tremendous implications for research. It has tremendous implications for application. It has tremendous implications for treatment. And we just haven't seen these kinds of developments and breakthroughs in medicine ever.
Whereas in the past we would sequence genes often one by one, we use different technologies now to basically be able to sequence all of the genes at the same time. So we use technologies to basically amplify or pull out segments of the genome that contain these coding regions, and then we sequence those all at one time. And with these newer technologies, we're able to basically do that in a very short amount of time, and much more cost effectively than the Human Genome Project would have been, a decade ago.
This is the coolest part of medicine. There is absolutely no doubt about it. I mean, everybody who wants to do medicine should be wanting to do this kind of medicine. And I think it's one of the greatest recruiters that we have to bring people into medicine, to bridge science and treatment. It enlarges the numbers of tools that we have available to make us and help us understand how we work and how we function. And I don't think there's been as exciting a time in medicine as this is. It is the coolest time to be in medicine, absolutely.
I've known Peter Byers for a number of years, and I have never seen him as excited about the promise of precision medicine. It's really true. We are now at the stage where the Human Genome Project will be moving to the clinic. This is transformation. Another area of transformative change in research is the ability to use a computational approach to designing proteins. These computer-designed proteins can recognize and interact with small biological molecules, and the approach provides a new way to develop improved, specific, precise diagnostics, new ways to develop therapeutics, new ways to consider advances in prevention, such as vaccine development. David Baker is the founding director of the Institute for Protein Design, and let's hear what David has to say.
We've been working on protein design for over 10 years now, and we've made some considerable advances. And the idea of the Institute for Protein Design is to take these scientific advances and try and translate them into the real world. So to develop better drugs, to start companies in the area that can really take our new capabilities and use them to make a world a better place.
I think it offers a really important advancement in the way we make medicines. Generally, medicines are made as very small molecules or very large molecules, proteins. The proteins are often natural proteins or antibodies. What protein design promises is to be able to make much, much smaller proteins that are uniquely targeted for exactly the effect that you want to have. So I actually think it will be revolutionary in the pharmaceutical industry as we can start to demonstrate that the promise of these molecules will live up in fact in clinical trials.
The type of problems that we're working on are viral infections. We're designing proteins that will neutralize viruses so you don't get sick when you get to prevent the virus from infecting you. We're also working on vaccines to help you mount an immune response so you don't get the infection in the first place. We're working on new approaches to autoimmune diseases like type 1 diabetes, and we're working on new approaches to delivering drugs so you don't have to take a chemotherapy agent systemically throughout your body, and instead you can target to one particular tissue.
Well, I think UW Medicine is one of the great academic medical centers in the United States. It's one of the best funded institutions in the world when it comes to biomedical research, and I think there's a very great environment of innovation, of partnering, of true collaboration between scientists. It's the quality of the scientists, the quality of the medical care that's conducted there. I think a spirit of innovation, of true exploration of new frontiers in science.
So overall, the UW Medicine is a fabulous place to be and to be building up the Institute. I think we're very close to a tipping point where if we can just go a little further, then the world will really be our oyster. We'll be able to solve problems right and left.
I think they said it very well. Some of you know Tachi Yamada. To put his comments in context, Tachi has a background to really be an expert on what we're doing with this Institute for Protein Design. Tachi was the chair of medicine at the University of Michigan, had a distinguished academic career. He and I got to know each other when we were chairs of medicine together. He left the academic environment, though, to go to GlaxoSmithKline to lead their research and development, was recruited from GSK by Bill and Melinda Gates to lead the Global Health Program as president of Global Health at the Gates Foundation. And then after leaving the Gates Foundation, he has taken his current position as Executive Vice President, Chief Medical Officer, and Chief Scientific Officer for Takeda Pharmaceuticals. That's the third largest pharmaceutical company in the world. Tachi is just one of many individuals who has seen this potential for protein design to really revolutionize how we approach diagnosis, treatment, and prevention of disease. Now, key to using the technology of protein design, key to using the technology of precision medicine is translational research. I could create a new acronym here and call this transformational translational research, TTR, but I won't do that. The importance of translational research has been recognized by the National Institutes of Health. The NIH now awards some of its very largest grants to support the infrastructure for translational research. We're fortunate to have one such grant here at UW. That grant is led by Nora Desis, who is the principal investigator and also the head of the UW translational research programs. We have made progress, but I want to emphasize that this is an area of transformation that I would say is relatively early. There is much more progress to go in supporting the faculty, supporting the staff and students who are linking our basic science work with the clinical research and the actual introduction of the product of that research into our healthcare system. To be successful with our transformation, we're going to need to invest in supporting that infrastructure, including the information technology piece that is so important to taking excellence in basic science to the bedside. I want to also emphasize that we're one of the world leaders in this area because we have the excellence in the clinical side, but we've spent many decades, 50 years, developing the excellence in basic science. We need to continue to build that basic science excellence, use a multidisciplinary approach, and link that more and more to what is actually happening in the UW Medicine hospitals and clinics. The year in review and the news items from around the world list a number of examples of how we continue to be successful in translational research. And I'd like to point out that we're building on history here. What happened in the 1950s at the UW School of Medicine with the development of kidney dialysis is one of the best examples of translational research involving engineers to solve a clinical problem. So we've been doing translational research for many years. We now have the opportunity to link so many basic science advances to the actual changes in clinical care. So speaking of clinical care, let me move on to continuous improvement that will lead to transformational change in our clinical care programs. I'll discuss just two specific examples, our Advancing Integrated Mental Health Solutions Center and our relatively new Palliative Care Center, and then briefly summarize some other progress with our strategic clinical initiatives. The UW Advancing Integrated Mental Health Solutions, or AIMS, yet another acronym, really began in some ways many years ago. Wayne Caton and some other individuals in the early 1980s began an approach that is now really this integrated approach to mental health care. Mental health care in the setting of care of chronic common conditions such as diabetes and hypertension. Over the last decade, there has been considerable evidence developed. So this is now an evidence-based, patient-centered approach to mental health needs, but also linking it to improved health in the care of those chronic conditions like hypertension and diabetes. If you apologize, I apologize for the aim of AIMS, but couldn't resist saying that the aim of AIMS is really directly linked to our mission to improve health. This is something that's going on now in our clinics. It's going on with the support of grants, federal grants. It's an example of linking research directly with education and directly with patient care. I am really pleased to be able to stand here today and make an announcement that an individual who has been a leader of these programs, Dr. Jürgen Unitzer, just today I have been able to announce has accepted the position as chair of the Department of Psychiatry and Behavioral Sciences. So Jürgen, welcome, and I'm sure that he's sitting right in the middle of the auditorium here. I am sure that we will continue to be a leader in this area that will be so important for our success as an accountable care organization. Like mental health, palliative care is going to be critical to our success with the triple aim, with our success, critical to the success of our accountable care activities. Randy Curtis, Tony Bach, and others have now fully established a UW Palliative Care Center. This is a center that goes beyond UW Medicine and the School of Medicine, includes the School of Nursing and multiple other health professional disciplines. It is truly a multidisciplinary center. It involves hospitals, hospices, nursing facilities, and families. Like the integrated approach to mental health, the Palliative Care Center is a terrific example of research being directly connected to education and to clinical care. Some of the funding for the Palliative Care Center comes from the federal government for the more research-related work in the center. Some of the funding comes for the educational activities that are needed as we learn how to be a better healthcare system in the way we treat patients who need palliative care. So this activity is very important for our future. Our strategic plan is continuing to develop. I've mentioned in prior talks how we are doing a continuous strategic planning process. That means our strategic plan will continue to evolve each year. Please, if you are interested in knowing more about the strategic plan, visit the website. We are inviting input at all times for the ongoing development of the strategic plan. The strategic plan, of course, must focus on specific objectives, strategic objectives, and then implementation plans for those objectives. As a strategic idea is developed and considered to be a good idea, it goes into a business planning process. If feasible to do it, we then move rapidly from that strategic planning work to the actual implementation. So each year we have a number of examples of strategic initiatives that are in the process of moving from the idea to the business plan to the actual implementation. Some examples of the implementation are listed on this slide. The new UW Medicine Sports Center at Husky Stadium that opens at 6:30 if you'd like to visit it early in the day. The UW Medicine neighborhood clinic expansion needed for success with the triple aim. Urgent care is very important for success with the triple aim. To really address the reduction of per capita cost, it's important for us to see patients in the appropriate setting for the patient's condition. The patient needs to see the most qualified healthcare professional in the most convenient setting, but also in the most cost-effective setting. That means we at times should be avoiding emergency room visits and going to the urgent care clinics. We have some of the best tertiary and quaternary care medical programs, surgical programs in the world, based primarily at UW Medical Center and Harborview. These programs are continuing to make advancements in areas like cancer care and cardiac disease. Our strategic plan focuses on continuing to advance those programs that care for the patients who have the most difficult illnesses, the most complex illnesses. And at the same time, working with our colleagues at Northwest Hospital and Valley Medical Center and with many individuals practicing in the ambulatory clinics, we must provide the very best of primary care, secondary care, and, as I've already mentioned, the urgent care. Specialty work is always changing a bit, and changing in areas where there is demonstrated need. The global burden of disease study that will now be ongoing by our Institute for Health Metrics has identified one of the most rapidly increasing health problems. One of the burdens of disease is cognitive difficulties, meaning memory loss, Alzheimer's diseases. And we are responding not just with the excellent neuroscience and basic science, which we need to continue to build, but also with attempting to take this to the clinic as rapidly as possible and have a brand new Harborview-based memory and brain wellness clinic. Last year, I indicated that we would be working on the transformation of UW-Medicine to become an accountable care organization. This year, I can announce that we are moving along that path that I defined in my talk last year. We are, at this very moment, working on a set of contracts with payers for healthcare that will be accountable care contracts. These contracts, some will go in effect as soon as 2015. So we are on the path to be an accountable care organization in 2015. And I say that in the sense that our hospitals, our clinics, our physicians, and other healthcare professionals will be working together and in a very real sense partnering with the payers for healthcare, the commercial insurance companies and others, to do our very best to define a program that is consistent with that triple aim of better health care for the individual, better health for the population we're serving, and doing our part to control the per capita cost. This work on transforming our hospitals, clinics, and healthcare professionals to be an organization that can be a leading accountable care organization is perfectly consistent with the mission of improving the health of the public. I can't think of a better set of activities to support that mission of improving the health of the public. It's also very consistent with what we've been doing in the clinical setting, that is in our hospitals and clinics, in a program that's called Patients Are First. This program has goals associated with it. If you're interested, again, this is a program that you can read more about in the UW-Medicine homepage. It's a program that has pillar goals that sound very similar to the what I've described as the triple aim. So our transformation to be a leading accountable care organization is consistent, is supportive of our mission to improve the health of the public. It's going to be consistent with the triple aim objectives, and for us, in simple terms, it will allow us to have the continuous improvement we need in our quality of care, the safety of our care, the access patients have to our care, and the actual service, the communication, the service and satisfaction that patients achieve when they place their care in our hands. So I want to emphasize that the dots connect. The mission connects to being an accountable care organization. The accountable care organization will allow us to advance what I personally have wanted to see us change for many years. And when I said I'm so enthusiastic now, it's because I do see this ability now to change in a positive way, to transform faster than we've ever had that ability to do before. I am not going to list a large number of report cards where we receive really good grades, but I can't resist showing a couple report cards. Our hospitals continue to be recognized as hospitals that are among the best in the state and the best in the country. The Joint Commission, which performs a careful, very careful review of all hospitals, found only 3 hospitals in King County that met their criteria for top quality in 4 important areas of heart attack, heart failure, surgery, and care of patients with pneumonia. So Harborview and UWMC were joined only by Overlake Hospital in meeting this recognition by the Joint Commission. All of our clinical sites, Northwest Hospital, Valley Medical Center, our clinics, really all of our clinical sites are recognized very regularly by their accreditation associations, like the Neighborhood Clinic recognition of the top scores for accreditation from the group that provides that oversight for ambulatory clinics. Valley Medical Center receives many awards. One that is unique in our state is Medicare Best Hospital for Joint Replacement. Valley Medical Center is the only hospital in our state that received that particular recognition this past year. Both Valley and Northwest have a number of honors from the American Heart Association, and Northwest Hospital has received many honors related to its clinical performance in areas such as stroke, critical care, neuroscience, patient safety from an organization called Health Grades. Northwest has also been recognized for the clinical excellence of its joint replacement. These are just a few of the multiple indicators of the success of the clinical programs in leading in quality. So let me now move to transformation in the educational arena. Again, we are in an overall UW Medicine continuous strategic planning process, and we are doing that now also in education, where we are involved in a continuous curriculum renewal project. Transformational change in education really is needed everywhere in the world. In our case, as the 5-state medical school with the responsibility for educating future physicians for the states of Washington, Wyoming, Alaska, Montana, and Idaho, we need to be very cognizant of the regional workforce needs. And our plans in education of health professionals really need to be directed to that commitment we have for the 5 states of the Northwest. The WWAMI program is alive and doing very well, and I'll have somebody who can say more about that tell you by video about how well the WWAMI program is working. Before showing that video, I want to emphasize that just like we have Patients Are First to guide us in the clinical setting, we need to be guided by several principles as we consider the next set of changes for our educational programs. We need to place active learning as a top priority. Active learning must be a principle that's applied whether it's in the classroom or in the clinical teaching setting. We must really also do more with lifelong learning. We are all learners. It's not just our students or our residents or our fellows. We are all continuing to learn. We need to continue to develop our educational programs to support each of us as learners. That means we have to support the best possible learning environment. We need a learning environment that is respectful, that is professional, but still a learning environment that challenges us to ask questions, to answer questions, and to have active learning be the way that we work together. The health science deans have been working this last few years on doing more with interprofessional education, and I'll say more about that in a minute. A few notes about success with meeting regional workforce needs by developing programs that are oriented to the workforce. One example is our region needs more physician assistants, and just in this past year, the new Tacoma site for the MEDEX physician assistant program opened. This past year, we started a pilot project for second-year medical students in Spokane. This places the medical students for that second year in the community, in some cases where they grew up, in some cases where they will go to practice. Our region definitely needs more graduate medical education, and I hope to actually say more about that next year due to some activities that are ongoing at present. In the past year, we have had some success. There's a new pediatric primary care residency experience that Bruder Stapleton and his colleagues have supported in Anchorage, Alaska. There's a new internal medicine program in Billings, Montana, a new family medicine program in Missoula, Montana. There are examples of other programs that are growing a bit or are linking together so that they can work together more in this whammy model of working together as a region. So there are multiple examples of how the WHAMMY program that was founded now 43 years ago, and we're fortunate today to have one of the founding fathers of the WHAMMY program sitting up front, Dr. Jack Lean, who I must always recognize as a father of WHAMMY, so welcome, Jack. And now let's hear for a minute about how the WHAMMY program is working. I have to do my part. Oops.
We're in Lewistown, Montana at the Central Montana Medical Center. Lewistown is a town of about 6,000 people. It's actually right in the center of Montana, the geographical center, and it's an agricultural community. There's a lot of cattle ranches around. There is some farming. Can I listen to your heart and lungs? I joined the TRUST program and graduated from the University of Washington in 2012. Can you lean forward any? Thank you, sir. TRUST stands for Targeted Rural Underserved Track, and it's a longitudinal program that lasts throughout your 4 years of medical school. It's integrated into it. You do training before you even start medical school in that community, kind of get introduced to it. And then after that, you come back several times during each year, and then in the summers between. And then during your third year is when it kind of all accumulates, and you do 5 months here, and you do all of your outpatient medicine in that community.
Does she mind her tummy time?
Dr. Bennett has been a mentor for me over these years.
There we go.
Actually, she's always treated me like a colleague.
So we like to go right on the skin.
She's always asked me, what I felt we should do in a certain situation, or if I had any other ideas, or if there was something I really felt strongly about, a way to treat someone. She always wanted me to pursue that.
Not bad for a 78-year-old woman.
Pretty good, I would say.
As I've seen that longitudinal education process progress, I think that is truly the future of medicine. I think for medicine anyway, but I also think for especially rural medicine, because the only way we really can have good quality health care anywhere in the rural U.S. is to be able to give young doctors the confidence and the knowledge of what it's like to be out here, and the excitement and the relationship, and why did they go into medicine. And honestly, it's a lot easier to do it in this kind of setting just because they get to see it in place.
I like being able to know families. I like to know, that I've delivered a baby, and I get to see the baby and the mom, for months afterwards, and then I know their grandma, and I know their, uncle, and you learn a lot about families, and you learn a lot about their social life, which is really important in medicine. I grew up on a ranch in southeastern Montana, pretty remote, about 50 miles from the nearest town. So I actually went to a one-room schoolhouse. The people in small communities are just really loving. They help each other out because you don't have anything else when you're out there.
Take a look at your legs.
I knew I wanted to come back and be one of the people who, you know, help people when they're at their lowest or highest points in their lives and just give back to the community.
We'll take a look, make sure you're on some blood thinners.
Oh, she's going to be a great doctor. She's going to be wonderful. I mean, she's confident. She's not afraid to work. She's energetic, but she is unbelievably empathetic. And the patients just, I mean, it's just her being here, the patients go, gosh, I sure like that doctor. She really talked to me and she really told me things. And, you know, she has that wonderful skill of being able to educate patients too, because that's a lot of what we do.
I think the TRUST program is just a very unique program. There's nothing like it in the country for medical students. It's, you know, it's one of the only places where you can really get to know a community and a set of doctors and a set of patients. And it's an opportunity for you to, you know, grow within yourself and learn about all aspects of medicine.
Our education programs are changing. They're changing more rapidly than ever before, and I really believe they're changing for the better. Preview of coming attractions for next year, when I'll be able to say more about some curriculum changes coming out of this continuous curriculum renewal process. Today I want to recognize the literally hundreds of individuals who are involved with this process. We have Mark Whipple, Robert Steiner, Tom Montine, Richard Veith, Michael Ryan, Norm Beauchamp, Wiley Burke, and Ellen Cosgrove helping to lead. But this is really work that is being done by hundreds of faculty in Seattle and around the WWAMI region, and our students are definitely involved in the process. I've mentioned the interprofessional education initiative that the health science deans are supporting. From our school, Karen McDonough has played a great role in moving that initiative forward. We can't be successful with lifelong learning, with doing the best active learning with our students, unless we continue to improve our learning environment. And our Committee on Continuous Professionalism Improvement, note this continuous improvement approach to all that we do. That committee that Carlos Pellegrini served as the founding chair of the committee has done truly excellent work this past year in improving our learning environment. And Carlos has turned over the leadership of that committee now to Dr. Molly Jackson. So I want to thank Carlos for that excellent founding work. This past year, we have made an important change in the way we approach our strategic goals and objectives around diversity, equity, and inclusion. And that includes creating a center titled the Center for Equity, Diversity, and Inclusion. I'd like to thank Victoria Gardner for her role as the acting Chief Diversity Officer, and we are now, I believe, nearing the end of the search process. This program will be, I think, instrumental in creating the excellence we need of a diverse group of people working together. I will mention the Seahawks, I guess, one more time. When you think about the Seahawks and listen to the mix of individuals, the individuals from truly diverse backgrounds, the players, the coaches, the support staff, the Seahawks are a great example of a team of people coming together from diverse backgrounds. UW-Medicine needs to be the team that values diversity and has individuals from those diverse backgrounds working together for the common mission. So, 2014, what are we doing this year? I don't think you will see any surprises in the next few slides. We are in the process of transformation. We've had a blueprint for a number of years. We've been making changes for a number of years to prepare ourselves to do a better job of connecting basic science to the clinical research and clinical care. We've been doing things for a number of years to prepare us to have the metrics to achieve the triple aim. So I don't think you'll see any surprises in these plans for this current current year. We need to continue our focus on acceleration of translational research, and this entails both the support of basic science excellence connecting that basic science excellence to the clinical setting via clinical research. That creates the connection of all of our research to the mission of improving health. This acceleration of translational research, in my view, has never been more important. To improve funding from the National Institutes of Health, we need to do a better job of communicating to the public, including to our elected representatives, how the research is advancing individual health care, but also really taking into account the need to control the per capita cost of health care. So we need to connect what we do in research with what our country needs to improve the health of the population of the United States. This really is all coming together for us now. The clinical programs have been changing faster than our other programs in many ways for the last several years. And these changes are intended to put us in the position in 2015 to be the leading accountable care organization in our region and one of the global leaders in this focus on the triple aim. Infrastructure is needed for all that we do. We need better infrastructure to succeed with acceleration of translational research. We clearly need to continue to focus on the infrastructure to support the healthcare teams, the way we deliver using an interprofessional healthcare team, the way we deliver care in the clinical setting. The teamwork also extends beyond the walls of the 4 hospitals in UW-Medicine and the clinics that are in UW-Medicine. We need to work effectively with our partner organizations. We are closely partnered with Seattle Children's Hospital, closely partnered with the Fred Hutchinson Cancer Research Center. And along with Children's and the Fred Hutch, we're co-owners of the Seattle Cancer Care Alliance. We have faculty and students at this VA, Puget Sound Healthcare System, and at the Boise VA. We have a number of key partners that we need to include in all that we do. We also are now moving beyond the sites where we have UW faculty doing research, education, and patient care. We will be working with other organizations outside of our walls. As we do this work, though, I want to emphasize the last bullet on this slide. It is vital that we maintain a consistent focus on quality, safety, service, access, cost effectiveness, and efficiency. I feel that's my job in developing the infrastructure to support that for our clinical system. And I really want to emphasize it's very important we integrate what we're learning how to do better in the clinical system to connect so that what we're discovering in the translational research can then move to education and then move to actual clinical practice. Next year, I'll report more on the implementation of, or the plans for implementation of a new curriculum for our medical students. This will be a major change in the way we educate our medical students across the 4 years. This blueprint is still being developed, again, with the input of hundreds of individuals, so this is very important work on what we have called continuous curriculum renewal. Our region is the most underserved region in the country for residency positions for graduate medical education. So a major piece of work this year is going to be exploring better support for how we can grow graduate medical education. Again, I hope this can be an item that I will cover next year. We need to also continue the approach of always trying to improve our educational programs for graduate students, PhD and master's degree students, and undergraduate students. there are more than 1,000 undergraduates involved with us, and we need to use a continuous improvement approach for our education, whether it's medical students, physician assistant students, residence fellows, or undergraduates or graduate students. The work the UW-Medicine community has done has truly reached around the world, and in the last year, I believe it was, I showed a slide that indicated that on any given day that there are approximately 2,000 UW-Medicine people in 90 countries around the world. This year I wanted to show a slide of the penetration of your work, of the work of the UW-Medicine community in the United States. Thousands of individuals across all the states in our country have been trained by UW-Medicine. This is a major way that we can influence the health of the public across the country. So it's a great example to me of how the WWAMI program, how our emphasis on integrating education with research and patient care, I think is now having an impact across all the states in our country. And speaking of global, I want to finish with an example of how what we've learned in the WWAMI program is now extending to other parts of the world. In particular, we're going to hear from a faculty member in the Department of Medicine and the Department of Global Health, Dr. Carrie Farquhar, about a program in Nairobi that is really a WWAMI program that we're doing with a country in Africa.
Yeah, so I do HIV prevention research and also training, and I think both of those synergize. We've seen incredible progress towards, in Africa where people are not dying at the rates that they were before the PEPFAR program came through, which is the President's Emergency Plan for AIDS Relief. Through the International AIDS Research and Training Program, we've had almost 50 Kenyans come to Seattle and participate in a degree program, master's and PhD degree programs. And each of those doctors has a mentor from University of Washington as well as a mentor in Kenya.
I'm from Uganda. I'm currently a student in the Department of Epidemiology. So my degree program ran through 2016, spring of 2016. And when I complete, I'll go back to the research facility I work with in Uganda, where I'm an investigator, and I'll continue working in HIV prevention.
We provide them with role models for mentorship, role models they might not otherwise have had in their academic system. And then they, in turn, are training many, many more students and fellows. So I think the mentorship is incredibly powerful.
We get the skill set, we get the resources, we get the funding from our collaborators here in the West, and we have access to the communities back home. We have knowledge of the local problems. And so together, because two heads are better than one, and many hands make light work, we're able to bring our combined expertise to solving the critical public health problems of our time.
It's called the Medical Education Partnership Initiative. And we were fortunate to collaborate with the University of Nairobi. James Chiari specifically is the principal investigator, and he also earned a master's in public health here at University of Washington. And we partnered with him to develop an innovative model for medical education at University of Nairobi. They have been facing a challenge of needing more doctors out in rural areas. So we borrowed the WWAMI model as a means to enable the University of Nairobi to branch out and train their medical students in rural sites. And what the students are finding is that they're having excellent hands-on experience. They're getting superb clinical mentoring as well, because there's a component of training the doctors there too on how to mentor and how to work with these students. They are able to take more responsibility and see problems they might not otherwise see. And also the emphasis on that next generation, both here at University of Washington, but also in Kenya. I think we have many more decades of great work in HIV and beyond, because everything we do in HIV work, I think, will benefit health in general, the survival and decrease in disease.
HIV is a global problem, and the burden of it is in sub-Saharan Africa, and that we are going to need to work together as multidisciplinary teams, because nobody working by themselves is going to solve this problem. But when we bring our resources together and work together, we can defeat AIDS, and the end is in sight. We can see it coming.
The reach of the UW Medicine community truly extends around the world. I'd like to conclude where I began, with a thank you. I'm so grateful for the excellence of the teaching, the research, and the clinical activities that you all conduct on a daily basis. The people of UW Medicine are a unique resource. You are the individuals who are advancing the mission of improving health. You are the individuals who are going to achieve better health care for the individual patient, better health of the population we serve, and you're going to all help us together to reduce the per capita cost of the care. The dots really connect. What the people of UW Medicine have done since really this school was founded in the 1940s has been working to integrate excellence of research, of education, and patient care to improve health. So thank you all very much for your contribution to that mission of improving health. And please join me now for a reception down the stairs. Thank you all for being here today, and go UW Medicine.